Welcome everyone to Einstein's Eyes, John and I's our YouTube channel. It is named after Albert Einstein College of Medicine, where John and I trained as ophthalmology residents many years ago. I'm an oculoplastic surgeon and neuro-ophthalmologist, primarily focused on oculoplastics, not in Anchorage, Alaska. And my friend John.
Hi, hello everyone. I'm Jon Ditkoff. I'm a cornea specialist who also does general ophthalmology. I'm located in northern New Jersey. And it's good to see Carl, and it's nice to meet Dr. Fisher. And I'm looking forward to this talk.
And so we have a real treat today. Dr. Fisher, Jonathan Fisher, a cardiologist by training, who has written a book, Just One Heart, a phenomenal piece of literature, really very good, focuses on areas in medicine that are not talked about widely, but are very important. Dr. Fisher is going to describe his background, and then we're going to get into it. And let's kick it off with Dr. Fisher.
Thank you so much, Carl. John, it's great to be with both of you. I hope to visit both of you. John, I was in Jersey 2 weeks ago visiting my 97-year-old dad, who was the town physician in Livingston, New Jersey for a few decades. Yeah. And then Carl, one of my favorite trips was to Alaska with the family. So it's great to be here today. It's funny.
Where are you located?
I'm in Charlotte, North Carolina, after I spent a decade in New York City. So I was in the neighborhood of Einstein. I was at Mount Sinai on faculty there after doing my fellowship and my medical school. And then I spent 3 years in between up at the Brigham and Women's Hospital, where I did internal medicine training.
Oh, wow. Nice. Very impressive.
So it's funny that you're calling this the Einstein's Eyes, because my book opens with a story about Albert Einstein.
Oh, that's awesome.
And the reason is, I'm from a medical family. My dad was the town doctor, and that's his leather bag that he used to do house calls with in the 1950s. And my mom and dad were into science. And so we had one larger than life picture on our living room wall. And this is like an academic Jewish family. And so it was nobody in our family. It was Albert Einstein. So I grew up with Albert Einstein looking down at me we're all thinking we want to be like that guy, but I hate to say it, I'm no Einstein.
I don't think either one of us are either.
Yeah, I am definitely not in that category. No worries there.
Yeah, so I grew up and really inspired by my dad and 6 brothers and sisters who were physicians before me, and I chose to go into medicine because I had a natural inclination towards physics and science. My mom was a nuclear physicist, and I ended up going to Mount Sinai in New York, and then Boston, and back to New York, and eventually decided to get out of the city as I was raising kids. So we moved to Charlotte, North Carolina, where I've been for 16 years. And I work in a multi-state system, one of the largest in the Southeast. We have 38,000 employees. And I have to say, I love practicing cardiology, but they were many, many rough years. And about 15 years ago, I found myself in a state of not only burnout, but of deep depression. And part of my healing from that was to start investigating, researching, how do I get out of depression? How do I deal with anxiety, which I had my whole life? How do I do it in a culture of medicine where we don't talk about these things? Do you think that I was advertising at Harvard that I was struggling with anxiety and depression? It's not something that we like to advertise because we think our colleagues are going to judge us, our patients are going to judge us, we're going to lose our license in some states if we admit some of these things. So I really was frustrated and angry and really alone, and something had to change. It started with a lot of inner work where I studied the field of psychology and positive psychology. I started seeing a therapist. I discovered meditation, mindfulness, yoga. And then slowly I started to share my story in the corner by the water cooler, and other doctors started to kind of lean in and say, what are you doing? Because we're all miserable too. How can we fix this problem? And that was the beginning of the last 15 years and really a shift in my entire career, so that I spend half of my time as a practicing cardiologist, and I spent half of my time at an organizational level as an executive trying to end burnout and to promote the well-being of our doctors and nurses, and we have several thousand of them.
Wow. Wow. That's a powerful story. Thank you for sharing that. Yeah, I mean, I suppose I'll add my own trajectory. I'm the only oculoplastic surgeon and neuro-ophthalmologist in Alaska. And
Wow.
yeah, I've been doing that for 30 years. I've taken call every day, trauma call,
Mm,
because I fix facial fractures.
mm,
I work with neurosurgery and ENT
mm,
primarily. So yeah, so I felt the burnout too. And I actually took time off.
mm,
I went and got a policy degree.
mm,
Started a company to kind of distract me, sold that, and now only work 2 days a week. But I completely get it and sympathize with the physician burnout, and I see it all around. I will say, though, that the newer generation is different than my generation. And John, I mean, you're a little younger than us, but we hired two new ophthalmologists, and they're really working 3 days a week,
mm,
and they really care about work-life balance and well-being, and that may be baked in from residency or medical school. I'm not privy to it, so I can
mm,
only conjecture, but it's certainly a different, it's a change in the way they think about medicine.
mm.
But I mean, John, what about you?
Yeah, I mean,
you're
it's
still
very
working
interesting.
hard.
Very interesting to hear Dr. Fisher because I grew up in a house. I have three brothers. My dad was a physician, so I grew up kind of thinking working 7 days a week, and that's the norm, and toughen up. And I think two of my brothers are physicians. I'm a physician, of course,
Mm,
and my other brother did corporate law, which was very intense.
mm,
And we all went through things like this. I mean, different degrees, and I think we all learned our own way, kind of like how
yeah.
you found your way.
Mm,
We all found our way to kind of deal with the stress and the anxiety of having an intense job and growing up in a family that's very driven, and we were all
mm,
very competitive. So I think it's really interesting to hear you talk about it. I
mm.
think I would have loved to hear you talk about it when I was doing my training. So, I kind of had to figure it out myself. And
Yeah.
and to Carl's point, I do think the younger generation doctors are kind of looking at things very differently than the way my dad did. And then I was probably a little bit less than my dad.
Mm,
But I do think it's not just the workload, it's also
yeah.
taking it home with you and worrying about your patients. And so that's
Yeah.
what I'm really curious to hear about. So
Yeah.
yeah.
Well, it's
Tell
great
us,
to.
yeah, tell us this strategy because I'm really open-minded to it.
So, John, the way you put that is, you wish you had this when you were in your training. And
Yeah.
when I talked to Kelsey, who, you all are connected with, our co-founder of the Ending Clinician Burnout Global Community, she asked me years ago, she said, "Why are you writing a book?" And John, I gave her exactly that answer. I said, "I'm not writing the book for anyone else right now. I'm writing the book that I wish I had when I was a first-year medical student, and nobody told me that I was going to lose my life, I was going to lose my happiness, I was going to be totally isolated and alone, and I would spend over a year in therapy, sneaking into the doctor's office because I was so embarrassed and I thought I was the only one." And I think that's got to end so that the three of us don't have to say, "Oh, I had that too, I had that too." And so, I put my heart into this. This is the book. It's called Just One Heart. And really what it is it's a summary of my research for the last 15 years into three different fields. One of them is the science of happiness, which is called positive psychology. And so I've interviewed 50 of the world's experts in positive psychology, mind-body medicine. The second field is in mindfulness and compassion. So there's a whole skill of developing an ability to relate to our lives in a totally new way, a calmer, more relaxed way, almost a stoic philosophy. And then the third is I wanted to become part of a conversation that I find fascinating, which is this idea of mind-body connection. For thousands of years, humans kind of knew that our mind and body were talking to each other. But for the last 500 years in Western medicine, there's been this sharp divide. The brain lives here and the heart lives here. They each need their own treatment, and that's it. And the more I practiced cardiology, I saw that my patients, even if I gave them an aspirin or a statin or we did a stent, They kept coming back to me with chest pain and high blood pressure and overeating. And I started to realize that what the problem was is we were treating the heart in isolation and just the physical dimension. And so what I write about in the book is the heart actually has 4 dimensions. There's the physical heart, the emotional heart, which has that symbol of the emoji, the social heart, which most people associate with the heart itself, empathy, compassion, love, and connection, the strongest predictors of survival. And then lastly, the one piece that most doctors and executives have zero comfort talking about, but this is the one thing all of our patients, studies show, want us to talk about. And that's the spiritual dimension of our heart, the spiritual aspect of our lives. And that's what patients care about. And so the book is my effort to bridge the 2 worlds, the scientific medical world and sort of the spiritual mindfulness psychology world, so that we can start speaking the same language through the lens of the heart.
I mean, I love the way, you approach it, and it sounds great. So as you said, it took a long time to get to this point, and part of the therapy was probably writing the book as well. At any point, how did you feel about psychiatric meds? I mean, anxiolytics. I mean,
Yeah.
how'd you feel about that? Or how do you feel about it now?
My feelings, John, have evolved.
Yeah.
My feelings now are very different than they were 20 years ago. I grew up in a family where, number one, no one talked about emotions. And if you don't talk about emotions, that means you don't talk about anxiety, fear, neurosis, and you certainly don't talk about lingering sadness and ongoing depression. So let's just say that, and I think you probably grew up in a similar family. It was a
Very.
generational thing where
Exactly.
nowadays we're more comfortable talking about it. In fact, it's almost all everyone talks about is emotions and
I
feelings.
think it's kind of become overindulged a little.
Exactly. And there's a risk of talking about it in the wrong way and over focusing on emotional life and misinterpreting regular everyday sadness and stress and calling it depression when it's really not.
Right.
So there was a time in my life, John, when I was completely against taking any medication for my mental health. I thought that once I started that, it meant that I was totally broken, that it would show up on my permanent record, and I would never want anyone else to know that I had to use that as a crutch because it was a sign of weakness. A guy who could do so well in school but was so delayed and essentially broken emotionally, I needed to take a pill. Come on. But you know who helped me through that? It was my wife. Leave it to your wife. So Julie was the one who said, there's no shame in using any means necessary in getting out of this deep, dark hole. I mean, I could barely go to work in the morning. I couldn't wait to get home at the end of every day. And I was seeing 3,000 patients a year at the same time as I was hiding behind a wall, a persona, a facade, pretending to be this brilliant doctor when I was just a gap, a shadow of a heart on the inside. So for me, John, I don't want people to think that you can do yoga and meditation and everything's wonderful. Those have helped me, so much so that I now teach other people those things. But for me, I also needed intensive therapy with psychologists and psychiatrists, and also taking medication. And for me, it's a holistic approach. I don't judge people for doing that, and I think we have to make it okay.
So I'll tell you 2 quick stories. I mean, medical school, I was in a 7-year med program. Imagine being surrounded by a pretty intense group. One of my friends, I remember we were taking behavioral science, and we started looking at him and he just wasn't acting right. And I remember, to your point about the family being in denial, we went to his family. I mean, it took a lot for us to do that and say, your son's not doing well. He's a close friend of ours. We don't know what to do. I think he needs help. And they said, oh, you know him. He's just a clown and he's messing around and he'll be fine. And thank God we were persistent, because he ultimately needed a lot of therapy and a lot of medication. And the second was a very close friend of mine whose dad, similar to yours and mine, was a guy that you didn't talk about emotions, and there was no such thing as psychiatric medications, and it was complete denial. And he's a very close friend of mine, and he was going through a horrible depression. I mean, to the point that I was very concerned that he was suicidal. And he was calling his dad for help, who is a physician. And his dad said, just snap out of it. I mean, this guy was in the middle of med school. Snap out of it. Snap, you'll be fine. And again, thank God, I said, no, you got to come with me. And within a week, I mean, miraculously, a week of medication, he was back on track. He ended up not missing any time in med school. And to this day, he's great on medication and therapy. So, I mean, these are great stories. I mean, but you could just imagine how many horrific stories are out there that we don't know about.
Yeah, we do. I mean, I didn't know where you were going to go with that story, and I'm glad to hear those outcomes. And it's really bears saying, though, what you didn't say, which is, unfortunately, oftentimes the stigma against discussing mental and emotional health, not just in our society, but among those of us who are held to the highest standard, the stigma is so great that 75% of us never seek help for our depression. And this results in the highest rate of suicide in any profession, 400 physicians per year. And those are old statistics. It's higher now. So I'm glad that you brought that up.
Yeah, it cost me, or partially cost me, a marriage. John knew my first wife back in residency. And I think I was so into, getting my career off the ground after fellowship that it just caused a rift that we couldn't repair. But I mean, there's a lot of reasons that somebody would get rid of me. So
Yeah, but I think the key thing really is, to Jonathan's point, is that people don't seek help, unfortunately. Like, they feel like it's a stigma, or they feel like it's a sign of weakness. And I think that's, it's definitely better than it was even without this conversation. I mean, if we had this conversation 30 years ago, people would be amazed. Like, they'd be like, what? I can't believe these doctors are talking about depression and anxiety. But I do think it's great that you've come out and talked about your own issues, because a lot, like you said, there's a lot of people now that can commiserate with you.
So, and just to make clear, sorry, Carl, to interrupt, but I want to be very, very clear about the reason that I'm sharing this story. I'm not sharing it because I'm asking for help or any kind of healing. I've done that work. The reason I'm sharing the story is that I want medical students and medical residents and medical fellows and young attendings and even senior attendings who may be in their mind or in their heart feeling these things, thinking that there's no way they can go on because they would lose their license, they would lose their friends, lose their patients. I need them to know that they're not alone. And I also need them to know that we're fighting to change policies so that every state doesn't ask you, have you ever had anxiety or depression, and potentially hold it against you. So for me, I wish I had role models as physicians who are just human beings, and not some kind of a superhero, because that's where we get into trouble.
We are asked a lot by medical school, by residency, internship, fellowship, by our patients, but do we need to be different than the regular population? And does that translate into those characteristics, those traits that filter us out and make us unique? So I agree with you about burnout. I get it, but are we distilled out, or are we unique in the population? And that's why we're here. Have you examined that?
Yes. The answer is we are unique. Psychological studies of profiles of physicians go back to the early 1980s, Carl. And there is a unique profile of the person who goes and chooses to become a doctor. There's no doubt about it. We are not normal people. We are people who have deep empathy, care, and concern for others. That's not everyone in the world. We are people who are willing to make sacrifices for long-term goals. Not everyone does that. We're often people who are willing to sacrifice our own well-being for the good of others. So there is a predisposition that we are already selected for once we make it into the school, which on the one hand is a superpower. It makes us good at what we do. And in my case, I had another superpower that a lot of doctors share. I am a great worrier. So if I have a patient who's having a chest pain, before they can think of one diagnosis, I've thought of 20 things that could be going wrong. While that makes me a good doctor, it makes me a very nervous, anxious person, and I had to do a lot of work overcoming that. So I'm not suggesting that we should try to whitewash all of those qualities away from our profession. What I am suggesting is recognizing that we are already predisposed to martyr ourselves, and we then enter into a system that is more than happy to take advantage of that. So we have to go in with awareness.
I think one other thing in terms of physicians that I always thought of being very different, whether it's, now that you said it, I don't think it's comes innately, but it's developed through med school and residency and training, is desensitization, right? Like you get really good at talking about terrible things with your patients, and somehow you kind of like you put that in another place. But I think inside you probably are feeling it. It's just you're taught to kind of suppress that.
Yeah. Jon, you bring up such an important subject there, and it's worth dwelling on because that is one of the drivers of burnout, believe it or not. And so you could either frame desensitization as a protective mechanism that all good doctors have to do to get through their career, to retire, but I would dare to reframe it in a different way and say it's actually more of a negative than a positive. Yes, we have to section off our emotions when they're running high. You know, Carl's not going to stop in the middle of an intense neuro-ophthalmologic surgery and start thinking about the patient's mother-in-law who's sick in the hospital, or, oh gosh, what if I make a mistake? And then he starts to get nervous. So that's not okay. We have to learn to separate them. But what we know happens to physicians is when we experience pain in our patients, when we witness death and dying, when we see accidents happen, that's a form of trauma or stress. And there's a well-known phenomenon that I was never taught about, and it's called secondary distress or vicarious trauma. So just by witnessing our patients have complications, just by witnessing our patients die, we develop the wounds ourselves because we are empathic. So the first step is to just call it out and say, we're not learning about these things and how this affects us through our career. The second step, and I do a lot of this work specifically when I train medical students and residents, is to teach them the difference between empathy and compassion. What you're describing is an experience of someone who witnesses something horrible in someone else's life, and they feel the pain that the other person feels so much that they have to shut it off inside. And that wall eventually causes you to feel depersonalized. You start stuffing down your emotions. Well, what's one of the 3 criteria for burnout? Depersonalization. So in a sense, if we take the approach that we identify with others' pain, our patient's pain, and by the way, the reason I know about all this is because I did all of this. I ended up in trouble because every time my patient felt bad, I felt bad. I thought that made me a better doctor. That's wrong. Right. That's what's called affective empathy, where you feel everything someone else's feel. It's possible to be empathic without experiencing the pain and going off the ledge yourself, and to turn it into compassion, which is to say, I can be with every patient's pain. I'm committed to do something to help it, but I also know the boundaries and the limitations of my own power within certain systems, policies, and procedures, and allow myself the grace that I can't heal everyone.
Yeah, it's very hard to do, but I mean, that should be a goal, I guess.
About you though, as a physician leader, let's just pivot on that. I did want to get to your organization that you and Kelsey created, the Global Community, and talk about, as you mentioned, organizational practices to really focus or shine a light on this topic. I'd love to hear your thoughts on that. Yeah,
so if you look at burnout, Carl, the literature goes back to the early 1980s and Berkeley and Christina Maslach and Leitner, and it really was an academic question of, well, wait a second, why are all our employees kind of quitting? And initially it was in the field of mental health. Mental health providers were just doing what we just talked about with Jon, where they were going over the edge themselves and running out of their empathy for other people. But now, in the last 10 years only, there's been a nationwide conversation about burnout, so much so that our Surgeon General, Vivek Murthy, 2 years ago, or a year and a half, released the Surgeon General's advisory on burnout in healthcare. So the reason I'm bringing up a little bit of a history here is to say to our young doctors who say, we've got to change the system, it's not happening. A little bit of history will show you that we've come a very long way. And it was only, 7 or 8 years ago that the first article in the New England Journal of Medicine was there on burnout. It was called The Crisis of Burnout in Healthcare by Victor Zhao at the Brigham and Women's Hospital. So we're in a very exciting time right now in healthcare. And like so many things, the healthcare industry, in my mind, I mean, you're the business experts, but in my mind, the healthcare industry lags behind other industries in all practices by 10 or 20 years, whether it's automotive or technological, et cetera. And so I'm happy to position the healthcare burnout question and well-being at work in the much broader conversation of modern, what's called conscious capitalism, which is how do we do business in the modern world without destroying the physical and mental, social, and spiritual well-being of the employee, which is a crisis right now. And what Jeffrey Pfeffer at Stanford wrote a book on it. And he says that most people are literally dying for a paycheck. And that's why I discuss in my book how burnout and stress at work increases the risk of cardiovascular disease and early death and reduces productivity. So we can talk about the solutions. They're complicated, but I wanted to just put that there as a kind of a framework.
Professor Pfeffer, I know his power course is famous at the Graduate School of Business. So day-to-day basis, just in terms of practical terms, what advice would you give a young doc or a medical student? They're just getting off the blocks, they're starting their careers. And what would you tell them regarding well-being and preventing burnout?
Yeah. Well, the first thing that I would say is that it's not all on them and it's not their fault, because most doctors naturally will start to question when we make a mistake or when something's not going well. What do? We say, what did I do wrong? And so a young doctor, we know that at the beginning of medical school, first year of medical school, there's an immediate increased risk of burnout. In fact, a good percentage of medical students are already thinking about quitting, going through the system today. So the first thing I would say, Carl, is that it may feel like there's something wrong with you, but you're definitely not alone. And it's not just America, everywhere around the world. You mentioned the Ending Clinician Burnout Global Community that we founded. At our first summit, we had 1,000 attendees from 43 countries. And every single doctor from around the world said the same thing, that when they were burning out, they felt that they were all alone. And so the first thing I would say to a medical student is, okay, just remember, you're not alone in this. Number two, I remind them, there are those of us who've gone through it before you, and we will not let it happen to you. And we're fighting for change right now at the highest levels, whether it's the Surgeon General who wrote that policy because he went through it, or whether it's someone like me who works in an organization which happens to be at the forefront of this, where we actually have a full department, fully funded and staffed department, measuring the causes of burnout within every population of healthcare team member, and we have dozens of initiatives to end it. So that's what I would tell the medical student. I'd say, number one, you're not alone. Number two, there is someone who's working for change. Just find us. And if they need to reach out to me and ask for help, reach out to me. If you want to go to the American Medical Association's website, they have steps for change on how to end burnout. Go to the Surgeon General's site. And then the other point I would make to the student, Carl, is most of the drivers of burnout have nothing to do with some lack of resiliency or personal flaw in the student. And that's something we might think, but it's not that. It's that we work in a system that often is driven by greed, often has perverse incentives, driving systems to want their doctors to do more tests for more money, often have third parties in the room, whether it's insurers or other companies that are trying to make dollars off the work of doctors. So I want to emphasize that burnout is an organizational problem, a structural problem. It's not an individual flaw. But here's the big but. The big but is even after we say that, since we are the ones, as we discussed, who are selected to go into medicine, we're naturally more sensitive, empathic, working hard, and ready to give up on our own needs. We have to do individual work ourselves. We have to learn the science of positive psychology and how to balance a full and flourishing life. And so I'll stop there, but that's kind of my initial shot across the bow.
Kind of wrap up the discussion today with practical ways to implement those suggestions. So, Jonathan, you're a physician leader. you're in a very large organization, much larger than John and I's small business that we run. And so what factors or triggers do you look for? Can you pick up, like we can, so John and I can tell, glaucoma, optic cup is large, the pressure is high. We know this suggests glaucoma. What factors suggest burnout? Are there ways to combat that? And what have you implemented to put sort of boundaries around folks so that they potentially don't get there? And then how much can you do? And do you have any anecdotal data or real data to suggest that these methods are bona fide?
Yeah. Yeah, so you asked a couple of good questions there. The first question is, can we measure burnout, and how do we do that? You also asked what are the best practices for an organization to end burnout and improve well-being? And the third is, do you have evidence that it's working? So in terms of the first question, Carl, it's like when a patient comes to see you and they've got a problem. We'll call that problem burnout, right? What do? You ask them questions. You examine them and you do some tests. It's the same thing. So the first step in any organization that wants to end burnout is they have to put the resources in, right? You have to give somebody a title and some time and even pay them, because this is important. And you have to start measuring the rates of burnout and well-being in the organization. And then you have to tie that to the fee, to the reimbursement of executives, the same way that you would tie the bottom line. Because unless you tie the incentives to the well-being of the workforce, no amount of morality is going to drive them to do the right thing, unfortunately. So the first step is to examine. And how do we do that? We do that with surveys. We ask questions. And there's very well-validated measures, Carl and John, for burnout. We ask, do you feel connected to others in your workplace? Do you feel like you have a balance in your life? Do you feel like people around you care about you at work? Do you feel like the organization gives a damn about you or not? And these are some of the ways, and then you can obviously ask, are you suffering from anxiety? Do you have depression? Are you sleeping at night? So these are some of the very basic, it's a brief questionnaire. And from that, we can tell who's at risk for leaving the organization, quitting, and potentially needing mental health support. And so we can get into the nitty-gritty, but doing that for 40,000 people, it's not easy, because you have to factor in not everyone wants to take time and answer the surveys. But the first step is you examine or take the pulse. The second step is you analyze the data and you say, okay, these are the 3 top reasons why our doctors are quitting, why they're burning out. It's the electronic health system, it's a lack of autonomy or control over their own schedule, and it's bad leadership. I'm just giving it as an example, but this is a very common sort of top 3. So in a sense, the research part is not that hard. You already know the answers. Then what you have to do is you have to empower local physicians in the office and say, we are going to hold you accountable for suggesting a change in your office. I want you to pilot it, a small change in your office. And then we're going to help you through the process over 3 months. And this, you're in the technology space as well. So you know that you don't make a plan for a policy change in technology and then check and see 5 years later how it's doing. You have to be agile. So remember I said that healthcare is 10 to 20 years behind. Well, healthcare has to be agile in improving the well-being of our employees, which means every week, every month, every 3 months, how is this pilot project doing? And in terms of what, now you're asking, well, what policies can you implement? One of them is workflow reform. Workflow reform. You can call that a lean or Six Sigma or eliminating waste. Again, this goes back 30, 40 years to Motorola and the automotive industry. Healthcare is just catching up with these old practices that are improving well-being. So you have to look at workflow. You have to look at leadership skills. So giving feedback to leaders when they're toxic, everything, you know what they say, blank rolls downhill. And the number one reason that doctors leave their organization and burn out is they have horrible bosses. So we have to become better leaders. And part of our program is to develop leadership skills, the same way you would get it in an MBA school, but teach it to the doctors so that they can help run the show. Healthcare systems that are run by physicians are often better run. I'm going to stop there because we
Yeah.
could talk for a
Yeah,
week
no.
about this. Yeah,
Yeah.
but I wanted to at least start off on that, and then I'm passionate about the other piece, which is the personal side, which is why I essentially wrote a whole book not on policy reform, but it's what does an individual person who's stressed out do? How do they get happy again? When they're dealing with grief or loneliness or sadness, what is the evidence base for the best ways to get well again? And it includes mindfulness, positive psychology, breath practices, psychological practices, some Stoic philosophy, et cetera, et cetera.
Ah, that was really wonderful. I
Yeah.
feel like I'm ready to read the book. I gotta get a copy.
Yeah, so just for the audience, Just One Heart by Dr. Jonathan Fisher. Jonathan, where can folks get the book and how can they
The cover is very Grateful Dead-y. I mean, is
it
that
is.
a,
Yeah.
I like it. I like it.
I like it. It's
Thank
very-
you. So this is something not everyone knows. This is a lotus flower in the shape of a heart. And the symbolism there is that if you know, a lotus flower grows in mud. It grows in muck. And so the idea is that even if things look bad, if you know how to plant properly and nurture the heart in all of its dimensions, it can grow, it can flourish in all the different aspects. So that's what that means. As far as where to find it, you get it on Amazon. Just go to Amazon, look up Just One Heart. You'll find it right away. And please let me know what you think. I'm not here to teach or to tell anything. I'm really just part of a conversation that goes back 3,000 years about the nature of the human heart and how we can start to see it. What I'm saying is we have to see it in a different way.
Well, thank you. Thank you,
That's
Jonathan.
Wonderful.
Thank you to both Jonathans, doctor. So this was a little different for us, and this was really great. I'm looking forward to further conversations, perhaps even how artificial intelligence affects this space. That's for another topic, but I just laid that down, and hopefully we can pick that up. Dr. Fisher, thank you so much. Jon Ditkoff, thank you, John.
Nice to see you
Okay.
guys.
We'll
Thank
see
you
guys
so
on the next
much.
one.
Wonderful.
Thank you.